Good evening, ladies and gentlemen. On behalf of the Sri Lanka Society of Gastroenterology, I would like to welcome you all for this webinar for the month of May. Today, it's a collaborative session with the Sri Lanka College of Radiology. It's a case-based discussion on common gastroenterological radiological conditions. In today's panel, representing the Sri Lanka College of Radiology, we have Dr. Eranga, who's a consultant radiologist at Lady Regional Hospital. And representing our society, we have Dr. Udaya Kalubowila, who's a consultant gastroenterologist at the teaching hospital Kandy. And we have Dr. Suchinta Tilakaratna, consultant GI surgeon and GL lecturer in University of Kalani from teaching hospital Ragama. And let me invite all our panelists to take over and take the proceeding from here onwards.
Can you see my screen?
Yeah. Yes, Suchintana, it's clear.
Yeah. So we'll be basically discussing the cases, mainly focusing on the radiological aspects. So the first patient is a 32-year-old female who got admitted with severe epigastric pain, and she gives a history of episodic right hypochondrial pain for the last 3 months. And on examination, she has a tender epigastrium. She is hemodynamically stable. These are her blood investigations. Her CRP is normal. Her amylase is markedly elevated. Bilirubin is also elevated, along with high alkaline phosphatase, gamma GT, and also elevated transaminases. So I'd like to ask from Dr. Udaya Kalubowila what you would think of the diagnosis based on these blood investigations.
Well, Suchintana, with elevated serum amylase with alkaline phosphatase and gamma GT, it would be likely to be due to pancreatitis secondary to Gallstone pancreatitis. So we had to proceed with imaging to exclude any CBD stones in this case.
Yeah. So Eranga, these are the images of the ultrasound scan.
Yeah, thanks, Sujinta. And first of all, let me thank everybody who's invited me. And so the first line would be investigating would be a ultrasound, basic ultrasound abdomen to see whether there's any available gallstones or whether there's any obstruction to the bowel ducts. As you can see on the left hand, the simple picture where you see the dilated distended gallbladder with multiple echogenic foci on the dependent part, demonstrating multiple gallstones. And you can see the wall is not thickened. There is no evidence of cholecystitis, no pericholecystic fluid, and gallbladder is not inflamed. And when you look at the image on the right side, you can see there is mild to moderate dilatation of intrahepatic ducts with a marked dilatation of the CBD. But the downside of ultrasound is sometimes when the patient is not adequately prepared, that is fasting and adequately, of course, these kind of patients are very ill. They might not be able to take orally, and depending on the clinical scenario, also the patient will advise not to take orally. So if you have not enough fluid in the stomach and the duodenal region, you might not be able to pick it up the distal CBD. So in this case, on ultrasound, you would say there is dilatation, but you cannot see a gallstone. Whether it has been passed because of the passage and edema, you still have the residual dilatation, but obviously there is gallstone. So there should be some sort of gallstone has passed, or there may be a distally lodged gallstone. So in this scenario, I think any clinician would be requesting at least a CT scan as a cross-sectional imaging if facilities are available, I guess.
Actually, patient underwent only a MRCP scan that right. is based on the logistics probably.
Yeah. So that's quite correct, because the MRCPs are much better, about 10 to 15% accurate than a CT to diagnose calculi, because some of the biliary calculi are radiolucent, especially the cholesterol calculi, which are not radiopaque. You might not be able to pick it up on even CT. But looking at these images, it's quite clear that you can see a signal void on the right-hand corner image, which is called the 3D image. If you're lucky, if you have very good images like this quality, you might be able to pick up a CBD calculus, which is in the mid CBD, not in the distal CBD. But you can still see some filling defects within the gallbladder itself as well. So it's obvious that the patient is having a CBD calculus, and make sure that you don't see only on these 3D reconstruction images. The images on the left and the middle are the best images if you want to find out a tiny calculi, which won't be able to, you might not be able to see it on the 3D reconstructed these images. So if you need to do very thin T2 images like this, where you can see the dilated CBD and you will see a tiny filling defects within the CBD. These are the best images that you can see calculus that you won't miss it on. But in nowadays, the practice has changed that we do MRCP combined with a CT. That is, that when you do, the accuracy goes another 5 to 10% increase of the diagnostic accuracy, especially in the distal CBD, where you might not be able to see a malignant stricture, whether it's secondary to a malignant stricture, so you don't want to miss a malignant stricture, whether the patient has developed a gallstone on top of some kind of a stricture. So these days we always do MRCP combined with a contrast CT, just to make sure that you catch everything in one setting. And you can proceed for these ones at a single setting, because for the MRCP you don't need to give any contrast, so you do with adequate fasting. At least 6 to 10 hours of fasting is the minimum requirement, so that you won't get any disturbance from the fluid in the duodenum or in the stomach. That is the minimum requirement for the MRCP. And straight away you can take once you do the MRCP, you can take the patient straight away and complete the CT scan as well.
Ranga, what would be the additional cost for the CT? I mean, the combination in addition to the MRCP?
Yeah, in the private sector, usually they have a little bit of a combination price rather than doing a separate study. So it will be another 20 to 25,000 added, just other than for a MRCP. So in between less than 50,000, you will be able to get the both done at a single go. But if you try to do it in a different way, it will be more than that.
Okay. All right. So just a small question from Dr. Udayarana Kaluboila. Now,
Yeah.
if you saw a common bile duct stone just from the ultrasound scan, would you
Yes.
proceed with ERCP, or would you still request MRCP and CT?
Actually, in this clinical scenario, with acute pancreatitis and with a gallstone, CBD stone, it would be better to proceed with MRCP, either which could be combined with CT. The one reason is to assess the severity and the complications of pancreatitis itself. As we all know, the CT would be, or the MRI would be sort of a better imaging with regard to the assessment of the pancreas and its complication. The second issue is to see whether there's any other calculi, hidden calculi in the CBD, and for the assessment of the biliary system. I suppose the CT and the MRI would be more sensitive compared to that of the ultrasound. So what do you think about Aranda? What is your opinion?
Yeah, I think it's the same, because if you do a ERCP, you will be able to just to see the CBD and the biliary tree. But whereas if you do a combined MRCP and a CT, you will get a whole idea of the severity of the pancreatitis and the complications of whatever the residual calculi, whether you have a cystic duct calculi, whether you have CBD calculi, or you have multiple calculi. So whenever you go for an intervention, you know you have a pre-planned, and you can manage it. And one more thing, if you're planning for a CT in an acute pancreatitis, you have to wait at least 48 to 72 hours to see the changes. Otherwise, you might not be able to pick it up because the changes take a little bit more time than the clinical presentation. So we usually recommend at least wait for 3 days for CT, but MRCT you can do straight away. There's no.
So with regard to the ERCP, when would you time the ERCP? This question for Dr. Uday Kalubowila.
So it would be earlier the better in this patient, depending on his clinical condition. I would think it would be earlier the better.
Okay, right. So, I mean, we would generally prefer to do it in the index admission, and even the cholecystectomy we can do in the same admission that there's no evidence of cholecystitis and also the pancreatitis is settling. Otherwise, we might see and then wait and do the cholecystectomy later, but there's a risk of developing subsequent attacks of pancreatitis.
Ranga, there's a question from the audience with regard to the positioning of the patient. They want to know whether the position is important in the assessment of the gallbladder, the positioning of the patient.
In ultrasound or?
In ultrasound, probably, yes.
No.
They have mentioned what it is. Yeah.
Usually we do it on supine, but sometimes turning the patient towards a little bit onto the left lateral, then the bowel shadows and everything little goes away from the gallbladder, then you might be able to pick it up small stones, but usually you don't need to position the patient to see gallstones if they are visible, except for the ones which are lodged at the Hartmann's pouch or at the neck. And when you're reporting also, it's very important to mention whether there's an impacted gallstone, because the management is quite different. And as sometimes we have come across those lot of impacted gallbladder neck calculi, which are causing cholecystitis. At times, then you have to go ahead and drain the gallbladder even sometimes.
Okay,
Thank you.
We'll move on to the next patient. This is a 54-year-old male patient who present with obstructive jaundice, and liver biochemistry confirmed the jaundice, and the ultrasound scan showed dilated intra and extrahepatic ducts together with mild prominence of the pancreatic duct. And this patient does not have any other comorbidities. So, Ranga, how will we plan the investigations?
So, Suzinta, I guess you are thinking of a pancreatic, some sort of a pancreatic neoplasm at this patient.
Yes.
So ideally it would be, we should go ahead with because the CT is the most available imaging modality in our country and most of the other countries as well. So the primary imaging modality would be pancreatic protocol CT. So, and there's an algorithm for pancreatic imaging, tumor imaging in radiology. So it will be, we initially do a pancreatic protocol CT set, that is, we don't give a positive contrast in these patients, because when you give a positive contrast orally, then the making MPR and assessment of the pancreatic tumor, as well as when you assessment of the operability will hinder because of the positive contrast, which will mask your multiplanar reconstruction. So in these patients, we usually generally give negative contrast, that is either water or a little bit of adding mannitol, which will retain in the bowel system, which good adequate distension. So you give negative contrast, and then you do a pancreatic phase, that is about 40 seconds after starting the injection. The 40 seconds, ideally, usually in other CTs, we do around 30 seconds liver image, but in these patients, we have to do a 40-second pancreatic imaging, followed by a venous phase, or plus or minus a delayed image, which is not really required all the time. So when you do a CT, if you see a lesion, then you have a different arm of going through, but if you don't see a lesion, but the clinical suspicion is high for a pancreatic tumor, then you might end up proceeding into a MRI, where I have another slide, we can see it later, that some of the lesions which are not seen on CT can be seen on MRI simply because the spatial resolution of MRI is much better than CT. And there's a place for PET CT, which if the MRI and CT are negative, sometimes you might be able to pick it up in PET CT because you have a metabolic, the active component that you are doing, lighting up the lesion. And of course, EUS also comes into play, where you might be able to see a tiny lesion which are not demonstrable on cross-sectional imaging. And then in the other arm, whereas you see a mass, then you have to decide whether these lesions are operable, borderline resectable, or non-resectable. So if you see a metastatic lesion, of course, you have to detailed assessment of these patients of metastasis. Where is the metastasis? Whether she has lung mets, and then you have to perform a biopsy to confirm the diagnosis. But if there's no metastasis and the lesion is resectable, then you have to perform a CT chest just to make sure that there are no lung mets. And if possible, if the facilities are available, you might end up doing a so that tiny liver lesions which might not be able to pick it up on a CT, since you are going in a direction of a major surgery in these patients. And there is, of course, there's a category called borderline resectable. And in those patients also, again, a CT chest and a biopsy and a liver MRIs are mandatory because before embarking on these surgical interventions. And there are few slides that I have prepared. Yeah. So in this, you can see easily the pancreatic tumors. Unless it is a neuroendocrine tumor, they are hypoattenuated. That means they are not enhancing as much as the liver and the pancreas. So the pancreas is whiter and the lesions within the pancreas will be less enhancing. So they will be little darker than the normal pancreas. This is the usual majority of appearance of pancreatic tumors. But if you are dealing with a neuroendocrine tumor, they will enhance more than the background pancreas. And if you can see this lesion that it's in the head of the pancreas, and it is very closely related to the main portal vein, but these lesions are not abutting or deforming the vein. That means these are resectable lesions. And if you move into the next category, I think Suchinta might explain what is borderline and what is resectable lesions.
Yeah. So the borderline resectable, so we have like the borderline resectable pancreatic cancer where the tumor is either abutting on an artery or encasing an artery, or where there is it's encasing a vein or infiltrating into a vein with occlusion, but there is proximal and distal vein margins where we can do anastomosis. In such situations, identifying that is very important because these patients need neoadjuvant chemotherapy with or without radiotherapy. And if you resect them afterwards, there are the chances that we might get negative margins is high. So the aim of a pancreatic cancer surgery is to get negative margins. And then we have these patients with, as Ranga mentioned, the metastatic disease. So in pancreatic cancer, identifying metastatic disease is also important. Except in neuroendocrine tumors, the pancreatic cancers, adenocarcinomas which have metastasized, is generally taken as non-resectable because there is no advantage in doing surgery in those patients. But in cases of neuroendocrine tumors, we can do the primary surgery and also debulking of the metastatic disease. So identifying all that is also important from preoperative imaging. And this chart is a guide to the concept of this borderline resectable pancreatic cancers.
And in these patients also, there's a place for PET-CT if you can afford it, especially the borderline resectable patients where you are contemplating a high-risk surgery. Then if you have the facility, you might do a PET-CT just to make sure that the lesion is just purely a borderline resectable lesion, as well as to completely rule out if there's any metastasis before embarking on these high-risk surgeries as well. And next slide shows a little bit of what you mean by borderline resectable. So if you have a lesion in the head of the pancreas and it's abutting the superior mesenteric vein, which shown by the white arrow, and you can see there's a little bit of flattening of the surface. That means it's abutting and deforming a little bit. But if you see it in the axial image, it does not cover up to the 180 degrees. So these categories falls into a borderline resectable, because the surgeons embark on these ones, they can safely take a margin out of the vein, I guess.
Yes.
Yeah, and the importance of the MRI also, these images have been shown. If you see the CT image on the right side, the patient was suspected to have a pancreatic lesion, but looking at the CT, you won't be able to diagnose any lesion. So this CT would come out as a negative for a pancreatic tumor. But fortunately, the clinical suspicion was very high, and they have ended up doing an MRI, which you see that when the lesions are not hypoattenuating, it's very difficult to diagnose on CT. But with whether they enhance or non-enhance, these lesions are easily picked up on MRI, because there are so much spatial resolution and they have different weighted images to make sure that you don't miss a lesion. The downside of the MRI is the patient cooperation and the technical aspect of technicians' ability to perform a proper MRI. Sometimes the MRI may not be as good as CT, purely because of this influential factors. Other than that, if you have a proper MRI technician and a patient is very cooperative, MRI would be much better to diagnose a smaller lesion.
So, Ranga, in case of like, let's say we detected a smaller lesion on CT, and would you recommend doing additional MRI as well for better staging?
No, unless you are thinking of whether there's any duct communication. If you want to rule out something like a IPMN or something which communicates with the system, then you have to do a MRCP. But pure and simple small lesion, you don't need to detect you don't need an MRI to further enhance, because if you detected it, you don't need to do it. But if you're thinking of a duct communication, if you want to narrow down your differentials, then you might end up doing an MRC to see the communication with the ducts.
And as a, like, when we are requesting a CT, would you like us to request as a contrast enhanced CT abdomen, or right, like CT contrast enhanced CT in pancreatic protocol?
If your clinical suspicion is high for a pancreatic, it's always better to write it as a pancreatic protocol, because sometimes sometimes the history is not very clear, and if you are not written a proper history for the patient, then we might think it's just a CT contrast. So then we might do a routine CT contrast CT rather than a pancreatic protocol. So it's always better, if your clinical suspicion is high, write as a pancreatic protocol.
And how sensitive is the pancreatic protocol CT in detecting liver mets?
Yes, almost as a CT abdomen, you can detect if the lesions are big enough, you can detect liver lesions. There won't be any much difference between the pancreatic protocol and the routine CT in detecting liver mets.
Okay.
But tiny ones, then you have to do an MRI.
Right. And then another thing that we use in diagnosis and staging of pancreatic cancer is endoscopic ultrasound. And EUS has good sensitivity for smaller tumors in T staging, in detecting vascular invasion, and also part of the nodal staging. And the added advantage is we can take a tissue sample. And especially in cases of when we are contemplating neoadjuvant chemotherapy, it's essential to have most of the time it's the oncologist would request a tissue sample and the diagnosis of a pancreatic cancer. The thing is, in Sri Lanka, still only few centers are doing endoscopic ultrasound, and I hope in future there'll be more people doing endoscopic ultrasound. So we'll move on to the next case. It's a 60-year-old male with child class A cirrhosis, and he was on surveillance scanning. He also has diabetes for 15 years, and on surveillance ultrasound, a 3-centimeter lesion was detected in the segment 4A of the liver.
So in these cases, the first line would be a CT if you are, because again, the availability and the cost and everything. So we have done a CT on this patient, and these are the images. Yeah, thanks. So if you can see, there's a 4A, there's a arterial hyperenhancing lesion adjacent to the IVC. And then if you move on to the venous phase, you have wash off. That means it's hypoattenuating compared to the normally enhancing liver. And in the delayed image, you will again see there it remains as a hypoenhancement and as well as a delayed enhancing capsule. These are the typical imaging findings of a smaller HCC, and usually there's a protocol for imaging in HCC, and the imaging protocol for HCC and in a cirrhotic patient. If you move on to the next slide. Yeah, so every patient who's a cirrhotic patient will have a 6-month interval surveillance ultrasound, and if you pick any lesion in the ultrasound, you will end up doing a CT, which is the usual imaging sequence. For the HCC imaging, usually you request 4-phase CT, that is non-contrast, late arterial, autovenous, and delayed imaging. These are the usual 4-phase CT. But in addition, in nowadays, we tend to do early arterial, because in early arterial, that means a 15 to 20-second image, which is not the routine practice, but we have come across many patients who's are doing 2 arterial phases makes the diagnosis of a HCC is much higher, because we tend to see when you do the CT in arterial phase, if you are not done it properly, you might see a lesion with being wash off, but because of the arterial enhancement, you don't appreciate it, then you will call it as a lesion is atypical HCC, or whether it's not typical for HCC. But if you do 2 phases of arterial, that is early arterial and a late arterial, the chances of picking up arterial enhancement is much better. Then of course, moving to the autovenous and delayed images will give the diagnosis. And just to make sure that these lesions are all starts as a regenerative nodule, which are venous in supply. But later on, when it develops into a dysplastic nodule, it will have an arterial supply, which will not have a venous phase wash off. But when it comes to a HCC, it will have the arterial enhancement, venous phase wash off as well, with a delayed phase enhancing capsule. But of course, if the findings are equivocal, but the clinical suspicion is high to have HCC, then the patient will end up doing a dynamic MRI liver, which is much superior on detecting HCC than a CT. Because again, for the same facts that I mentioned earlier, that the spatial resolution and the so much of sequences available at hand in dynamic MRI rather than these enhancement phases. So it will be the same as the enhancement pattern, but you have added T1, T2, and these diffusion restriction images as well to come to a diagnose and detecting lesions. especially if you have a diffuse lesion, if you have portal vein thrombosis. In these cases, you might not be able to pick it up typical enhancement pattern and HCC. So in these cases, the MRI is much added value. But in both, if the both imaging findings are equivocal, we might end up doing a guided biopsy to make sure that you are not dealing with a hepatocellular carcinoma. So as general rule, if the MRI are available and practically usable, if you detected a ultrasound, detected a lesion, doing a MRI would be much better than just a CT, because detection rates are much better on MRI. So then you can avoid a CT. And that all depend on the affordability and availability of MRI.
Iranga, what about the sensitivity of the CT for a small lesion, like either less than 2 centimeter or less than 1 centimeter CC?
Those lesions, if the lesions are hypervascular, you might be able to pick it up. But the chances are much less than doing a dynamic MRI. MRI, you will see it's much sharper image quality if you do a dynamic CT. But the problem is doing a dynamic CT. In Sri Lanka, only very few places have the contrast injecting pump. So they usually do with the hand injection, which is not the ideal way of doing dynamic MRI. That is the whole problem in this part of the world, or basically in Sri Lanka. But if you do a proper MRI, it's much better than a CT to detecting a smaller lesion, diffuse lesion with other complications as well.
So what would be the cost difference between a CT and a dynamic MRI on average?
Average about 7,000 to 10,000.
Right. So with that, there's a much more added advantages of
You can
MRI.
avoid a CT if you're lucky. Yeah.
And Iranga, what's the place of PET CT in case of hepatocellular carcinoma?
PET CT, of course, there's a place when you're contemplating treating with, if you're doing a surgical resection, you want to make sure that the lesions, which are only one lesion or 1 or 2 lesions, they are surgically resectable, and to make sure that you don't have any extra hepatic spread. So on these scenarios, you might do a PET CT, but apart from doing a CT and a dynamic MRI, detection rates are not that significant between PET CT and MRI.
Ranga, regarding post-trans chemoembolization surveillance to detect whether there's any tumor recurrence there. So what would be the best imaging? Would it be the MRI or the triple phase CT?
No, MRI. MRI is the best way of following up post-treatment, because the detection rates are much better.
And this
with this lipidoid cast as well.
Iranga, now you mentioned this surveillance in cirrhotics, the ultrasound surveillance. Now, once they develop a hepatocellular carcinoma and either we treat it surgically or with a ablation or something, what's the follow-up sequence of imaging?
Yeah, usually after any treatment from interventional radiology of point of view, we usually do after 6 weeks the first imaging. We tend to do MRI if possible, otherwise the same imaging modality which has detected the lesion, because if the same imaging modality has detected the earlier lesion, so if you're following up with CT, that is fair enough because you have seen that lesion in the CT initially also. So ideally you have to do in 6 weeks, and then if the lesions are completely gone and you don't have any recurrence or residue, then you do a 3 months. Then you do a 6 months, 1 year, and every year for 2 years, and still no, then you can do every 3 years. But in the meantime, you do the regular ultrasound surveillance, that is 6 months interval.
Suchintana, with regard to HCC surveillance, what we usually do is ultrasound scan every 6 months. As Iranga mentioned very correctly, there are some limitations. if there's high clinical suspicion, especially development of the resistant ascites or differential ascites, disproportionately high alkaline phosphatase, we have to suspect HCC even if the ultrasound scan doesn't show any evidence of HCC. It could be a diffuse type of a tumor. So therefore, I suppose CT might have to consider, we might have to consider CT for the surveillance if there's a high clinical suspicions. What do you think about Eranda?
Yes, exactly. Because the diffuse HCC, it's very difficult to detect on ultrasound, as well as if you have a very large lesion. I have seen few patients going back on to the, like, retrospectively also very difficult to understand that the lesion, if you have a very big lesion occupying whole of the one lobe, it might be very difficult to differentiating on ultrasound. But when, as you said, if there's high clinical suspicion, you have to always do a cross-sectional imaging, at least a CT.
Right. We'll move on to the next patient. We have the images of the dynamic pelvic MRI.
Sorry. Yeah.
Ranga,
yeah.
Can elaborate a bit?
Just the dynamic MRI. And so you can see that even without any contrast, the first one is the T2 imaging, next one is T1 imaging, and the third one is with the contrast. And you can see that even without any contrast in the second image, you can see the lesion, and the enhancement pattern confirms your diagnosis, but you might be able to pick up those lesions even before you give the contrast. So that is the beauty of doing a dynamic MRI of liver in a suspected patient with HCC, and the tissue characterization is much more higher, and you might be able to pick it up other, especially if the patient is developing a cholangio on top of a cirrhotic patient. It's much better to easy to diagnose on MRI rather than CT.
So here also you look for arterial enhancement, venous wash off.
Yeah.
Same features.
The enhancement is the same for both, but the tissue characterization is much better on MRI, so you can pick it up even without contrast, but you have to give a contrast to confirm the diagnosis. This is the only tumor that you would go ahead and treat only on imaging without any biopsies. So you have to 100% sure before you embark on any mode of treatment in these patients.
Yeah, as you mentioned, we have seen many, several cases where there was cholangiocarcinoma or intrahepatic cholangio in a cirrhotic patient, and it was difficult to diagnose only based on CT. Let's move to the next patient. It's a 60-year-old male with a history of rectal bleeding. On digital rectal examination, he has a palpable circumferential growth 5 centimeters from the anal verge. In the colonoscopy, rest of the colon is normal, and the histology confirmed moderately differentiated adenocarcinoma. So, imaging wise, how should we proceed, Ranga?
Yeah. So in these patients, there are two imaging you need. That is to loco-regional staging as well as metastatic screening. So if you move to the next slide, so for the loco-regional staging, MRI rectum is the standard mode of the imaging. If you have endorectal ultrasound, that is also very good to differentiate between T1 and T2, but MRI rectum will be able to stage the loco-regional disease. And then you have to make sure that you request CT chest and abdomen, not just abdomen, because you have to make sure that there's no lung metastasis before treating a rectal cancer. So it will be local MRI rectum and CT chest and abdomen for metastatic staging. And you have a role in PET CT as well when you're thinking of if you have a isolated or oligometastatic disease for the liver and you are thinking of doing a resection for the liver resection for the metastasis, then you have to make sure that there are no, you are not harboring any undetected metastatic disease elsewhere or even in the liver So PET-CT has a role in these limited cases. Not everybody, but if you are thinking of aggressive treatment with liver resection plus chemo plus rectal the surgical resection, in those places the PET-CT has a role, but not in everybody. So if you move to next slide, which shows sorry about the crowded image, but it gives the whole picture of what you're doing with MRI. So in the first line, what you're looking at to locate the lesion. So where it is, whether it's lower, mid, or high. It depends on the distance from the anorectal junction. That is for radiologists, but for the surgeon, it's from the anal verge. But we generally do it from the anorectal junction. So within 5 centimeters, it's lower, 5 to 10, it's mid, and 10 to 15, it's high. And in the lower rectum, you have to make sure that when you are seeing the MRI, whether the sphincter complexes are involved. That is in the very lower MRI image, you can see these, the external sphincter, internal sphincter, and the intersphincteric plane as well. In the mid and upper rectal tumors, you have to see where the lesion is. We generally tend to report it along the clockwise where the location of the tumor and the length of the tumor, that is from how craniocaudal extension of the tumor and extension into the mesorectal fat. If you look at the first MRI image on T2 weighted MRI image, the stars demonstrate the mesorectal fat. The fat looks hyper intense, that is white on MRI. So what we are looking at, whether the tumor has extended into the these and extending up to the mesorectal fascia. So depending on whether the mesorectal fascia is involved or not, the surgical resection varies. As well as you have to know how much of lymph nodes and the extramural vascular invasion. That means along small veins, the tumor can grow. So these are the things that you can report on MRI and to stage the local disease so that the surgeon will decide on the mode of treatment. So in the MRI, usually you don't need to give contrast. So any patient who's having even deranged renal function doesn't have to, you don't have to worry about it because we don't give contrast generally for rectal local staging. It's a just non-contrast, very specific high resolution imaging just at the rectum in all 3 planes to see the mesorectal involvement, extension into the mesorectal fascia, and how many local lymph nodes involvement are there together with the extramural venous invasion. And in the lower rectum, you have to make sure that you see the rectal sphincter complex involvement to decide on the mode of treatment, whether sphincter you are going to take out the sphincters or you are going to save the sphincters for the patient's reduce the patient's morbidity as well. So those are the major things that you would do a MRI rectum in a local staging. And then of course you have to do a contrast CT to rule out any distant metastasis into the paraiotics, liver, and into the lung fields. Those are the basic imaging algorithms for a diagnosed patient with rectal cancer. Unfortunately, the MRI is not able to differentiate T1 from T2. So to do that, you have to do an endorectal ultrasound to see whether the lesion is T1 or T2. But you can diagnose from T3, T4, and T1 or T2. You can differentiate only those 2 from MRI.
From point of view, the patients with distal rectal cancers, so based on the T stage, we might consider giving neoadjuvant chemoradiotherapy And also it's important to identify the liver metastasis and lung metastasis, because then the metastatic disease, treatment of the metastatic disease takes priority over the primary. And there are like a lot to debate about these things, but anyway, good staging, local region and staging is important surgically, because these patients can be cured. Unlike in pancreatic cancer, the patients with rectal cancer with even lung and liver mets can be cured. So it's important that we stage them accurately. So because of the time constraints, we move on to the next patient. It's a 35-year-old male who was complaining of abdominal pain and fatigue. His colonoscopy and the upper GI endoscopy was normal, and he was found to be having anemia. And I would like to ask from Dr. Uday Ranamaka, as a gastroenterologist, what are your thoughts about this sort of a presentation? Dr. Uday Kalubule.
Medical condition. The first thing is this could be a case of Crohn's disease, small bowel Crohn's disease without colonic involvement. The second possibility is this could be small bowel tuberculosis, or the third possibility, this could be a case of small bowel lymphoma. So therefore, we have to consider imaging if the endoscopic or the capsular endoscopic facilities are not freely available. So we would like to listen to Eranga's comment on imaging of small bowel.
So imaging small bowel with the new available newer high slice CT scanners and the MRI, doing a MR enterogram or a CT enterogram doesn't have a very much difference, specificity or sensitivity in between those two image modalities. But the only benefit of MRI would be there's no ionizing radiation involved, and especially in these kind of patients where you need to do follow-up studies. So it's better always if you can reduce the ionizing radiation, because generally these patients tend to be at a younger age and in reproductive age as well. So we tend to do MRI enterogram rather than CT enterogram, but the specificity and sensitivity are not much different in between those two studies. But if you do a CT enterogram, for the enterogram, you need to give adequate amount of oral mannitol, that is 2% oral mannitol, just to distend all the bowel loop, because mannitol is little hyperosmolar. It tend to absorb water into the lumen. So then the distension of the bowel loop will be much better than just giving oral water, which will be ultimately absorbed quickly through the intestine. And you can see these images where you can see that the normal bowel distance very nicely, but the narrowed and strictured segment because of the disease involvement. So in these patients, if you're suspecting of a small bowel lesion, a CT enterogram or a MR enterogram will definitely give the clue for it. And if you can see in the first image, you can see there's periluminal inflammatory changes with narrowing, stricturing, and this is called the prominence of the vasa recta, which called the comb sign. It's like a comb. You can see the prominence of the vasa recta, and always you might get a little bit of ascites also because of this ongoing inflammation. And if you can move into the MR images, so it will be the same, but for the MR, usually you tend to give some anti-spasmodic like a Buscopan or something, because the motions will give an artifact in MR. But if the sensitivity will not change between the MR or CT enterogram, but if you do it in a proper technique. And again, here also you have to give 2% mannitol. So the ingestion would be the same, just the machine technique is different, but you can see these strictures nicely on MR as well. And if you're thinking of lymphoma, in lymphoma and inflammation, of course, that there won't be a periluminal inflammatory changes in lymphoma generally, unless you have a perforation or something going on with some abscess formation. And in TB, usually you see it in terminal ileum with lot of lymph nodes around it. So the clinical suspicion can vary, but if the purely terminal ileum involvement, it might not be able to differentiate between TB or inflammatory process. But allowing there would be associated lymph nodal like lymph nodal enlargement, which are usually necrotic in TB, which will narrow down your diagnosis towards TB rather than inflammatory bowel disease.
Yeah. Any comment, Dr. Kalugula, regarding?
Yes, actually, that was very clear. So, especially in the absence of any endoscopic modalities, we have to consider CT introgram or MRI introgram. As Iranga mentioned, we would be able to narrow down our differential diagnosis and proceed with some invasive testing according to the imaging results.
So,
I just want to make sure that if you just do a CT rather than CT enterogram, you might not be able to detect subtle changes because these changes initially could be very subtle. And I have come across one patient where both CT and the enterogram was done by me, and the CT, even retrospectively, you can't diagnose it. So if your clinical suspicion is for an inflammatory bowel, please request for an enterogram rather than a CT abdomen.
So that we have discussed the planned cases. Now I think we can discuss if there are any questions.
Yeah, there have been some questions that have been sent in. Almost all are for Iranga. So the first one is, in acute pancreatitis, would you recommend CT within 48 hours for the purpose of diagnosis? Just for the diagnosis, I think.
Yes, for the diagnosis, please wait for 72 hours because even 48 hours, you might not see the change. If you're just for the diagnosis, please wait for at least for 72 hours.
And what is the sensitivity of small bowel ultrasound, especially in a thin patient? For Crohn's, I think. Yeah.
For Crohn's, yes.
Yeah.
If you're lucky, if the patient is thin and the inflamed bowel are just adjacent to the anterior abdominal, you can easily pick it up, those lesions. Because especially in children, at LRH, we pick more than the adults because there's less fat, and then the bowel loops are adjacent to the anterior abdominal wall. Then you can pick it up, but it will never rule out that possibility, because if you're diagnosed, you can diagnose, but you can say that there's no involvement.
Is it possible to detect these small bowel lesions in anywhere of the small bowel or just in the ileum?
No, anywhere. It depends on if it is depends on the body habitus, whether the loop is quite superior and adjacent to the imaging field. Depends on, but if you're lucky, you might pick it up, but doesn't matter. It has to be terminal or anywhere else.
And there's another question. Can we assess the function of the small intestine, that is peristalsis, by doing a MR enterogram?
No, because we generally give some Buscopan to reduce the motility usually. Because with the motion, it's very, there are techniques to assess the motility, but not in MRE.
Is MRI or CT enteroclysis better than MRI CT enterogram?
I didn't get you.
Enteroclysis, is it better than enterogram, either MRI or CT?
Depends, but enteroclysis is much better, but then you have to put the tube up to the duodenum, DJ junction and inject, so it will be almost, but the distension and everything is much better in enteroclysis if you can perform it. but we generally tend to do the enterogram instead of enteroclysis.
And for CT enterogram, I mean, any CT machine, could they do it, or is it?
Yeah. If it is more than 16 slices, most of the CTs in Sri Lanka now, it's more than 16 slices. So more than 16 slices, general CT abdomen, CT machines are quite good enough.
And what is the preparation for a CT colonogram? Is it same as for an enterogram?
No, colonogram is as for the colonoscopy. You have to have a proper bowel preparation. And for the colonogram, you have to do a supine and a prone because it's not a dynamic image. We do a CT. So you have to make sure that the bowels are very well prepared as for the good colonoscopy. And then you have to insufflate air and gives contrast. And you do supine and a prone image so that you won't mislead by a residual fecal matter, which will fall onto the dependent part. So otherwise you might end up labeling it as a small polyp or something when it just a, so that's why you do a supine and a prone image in CT colonogram. But it's preparation as for the colonoscopy. Low residue diet and bowel with clean prep and everything. You have to have a very good cleaning.
For CT enterogram, do you need to prepare with clean prep?
No. CT enterogram you don't need. It's just
Even
fast.
for
No. It's
even
just
for MRI enterogram, you don't need.
It's just as for a CT abdomen, no MRI.
And going back to the case of the liver lesion, if you go ahead with ablation, what do you think? Is it what is better, microwave ablation or radio frequency? Is there any difference between the two?
For the given image, it depends because microwave has a much higher power, and in Sri Lanka we have a single stein microwave only. In the RFA you have the like an umbrella one which you can have to open up the steins. So if it is very close to another major vessel or another organ, the opening up those steins are not very effective, and then there is no this heat sinking effect is not there in the microwave. So if the lesions are close to a larger vessel where heat sinking is going to affect the ablation zone, then the microwave is better. But overall, if it is if you give like both modalities are capable of ablating the lesion, the effectiveness is the same. There's no difference, but depending on the location and the availability and the depending on whether it's close to a vessel, that makes a difference between microwave and the RFA. But if both lesions are amenable for both modalities, the effectiveness is the same.
What was the cost difference between the two?
Cost is the same. There's no difference.
So those are the only questions that have been sent in. So I think we can wrap up today's webinar. So on behalf of the Sri Lanka Society of Gastroenterology, I would like to thank Eranga for sharing his expertise with us on behalf of the Sri Lanka College of Radiologists. Thank you, Eranga. And Suchinta for choosing these excellent cases and presenting them and providing his expertise in the surgical aspect. And also Dr. Udaya Kalubowila for sharing his expertise from the gastroenterological point of view. So I think thank you all for sharing your expertise and thank you for all the participants as well. And don't forget to fill in the evaluation form before you log out. Thank you.
Thank you.
Thank you, Kulisha. Thank you. Thank you, everyone.